This is an 11-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. The talks coincided with the launch of the Small C Public Awareness Campaign. The aim of these talks, and the Small C campaign, is to improve the early diagnosis of cancer. This talk is about upper GI cancer. This is the first of 4 on this topic. Part 1 looks at epidemiology, histology, risk factors, symptoms and diagnosis. This lasts for 11 minutes. Part 2 looks at investigation, staging, treatment, palliation and survival. Part 3 covers approaches to surgery and complications of treatment. And Part 4 deals with post-operative survival and Barrett's esophagus. The speaker is Francis Hughes, upper GI surgeon and lead clinician for upper GI cancer MDT at Barts Health NHS Trust.
Esophageal cancer then is the 9th commonest cause of cancer death in the United Kingdom, with about 8,000 new cases in the UK diagnosed each year. It's predominantly a disease of older patients, although the youngest I've ever seen was 16 years old, so it can affect the younger patients. It is more common in males than in females, but most importantly, the incidence of esophageal cancer is increasing more rapidly than any other cancer in the Western world. This is a graph showing incidence here. This is the incidence over the last 30 years, showing a gradual increase there for males, but for females a slight increase but not so marked. And this is for all types of esophageal cancer. If we look at the different histological types, you can see that squamous cell carcinoma, the incidence is fairly level and has definitely levelled off over the last 10 years. On the other hand, adenocarcinoma is continuing to increase and is predicted to increase further. If we look at data from the United States, it shows a similar picture for adenocarcinoma there increasing. That's for white males. In black males, there's also an increase in adenocarcinoma, but the incidence is not so high. But if you look at squamous cell carcinoma, the incidence is falling and has now reached to a point where it is below adenocarcinoma, and it's also falling in black males, but not to the same extent. If you looked at the entire world, squamous cell carcinoma is decidedly the more prevalent of carcinomas, but in the Western world it's now coming that adenocarcinoma will be either equal or more common, particularly in Europe. We all remember from medical school the risk factors for squamous cell carcinoma: smoking, drinking of spirits, achalasia, and celiac disease slightly increases the risk of squamous cell carcinoma of the esophagus. Adenocarcinoma, on the other hand, tends to affect more of the social class 1 patients rather than the lower socioeconomic groups, which tend to be more commonly having squamous cell carcinoma. Patients with adenocarcinoma often have a long history of gastroesophageal reflux. They tend to be obese. They drink alcohol, but it tends to be beer drinking rather than spirit drinking, and it's basically the large volumes of beer associated with curries, etc., that are refluxogenic. And family member diagnosed at a young age, there is now more evidence appearing that there is a genetic tendency for adenocarcinoma of the gastroesophageal junction, which we hadn't previously realised. And so patients who present with symptoms and diagnosed with adenocarcinoma under the age of 50 should probably have genetic testing. So we're all well aware of the typical presentation of patients with esophageal carcinoma, the progressive dysphagia, regurgitation, weight loss, chest pain, anemia, and very often signs of metastatic disease. This, unfortunately, is often the case when our patients finally present themselves. If we're looking to diagnose esophageal cancers early, it has recently been suggested that all patients who have more than 4 weeks of continuous heartburn should undergo endoscopy. And any patient who comes with dysphagia should have an endoscopy even after a single episode. This is the cytosponge. This has been developed in Cambridge, but basically this is a gelatin capsule. Inside it is a sponge, and attached to the top of the capsule you will see a piece of string. It doesn't take much imagination to work out that the patient is going to swallow said capsule holding on to the piece of string. The capsule will then dissolve in the stomach, and after a few minutes they pull on the string, and this sponge that has deployed will scratch some cells off their lower esophagus. That'll then be put into a cytosol solution and microscoped, and you can look for dysplastic cells. And if you find dysplastic cells, then the patient would go on to an endoscopy. If you think about the cost of this, I think it's £37 compared to an endoscopy at £600. It's got to be worth looking at. Nasal endoscopy is apparently less distasteful to patients. Biopsies can be done with the nasal endoscopy quite adequately, although it's probably not good enough for Barrett's esophagus, where you need to have a very good imaging system. Worsening symptoms in high-risk patients, so patients who we have are known to have risk factors. For example, they've got Barrett's esophagus, or they've got celiac disease, or they've got a family history, then those patients should have urgent endoscopy.
The urgent referral guidelines for upper gastrointestinal cancers state that people with dysphagia at any age should be referred urgently, as should those who have dyspepsia with certain alarm or risk factors. Other symptoms warranting urgent referral include jaundice, abdominal mass and back pain combined with weight loss.
And we need to think of ways to educate the public because the average patient doesn't present to their doctor until they've had symptoms for 4 months. Cancer of the gastroesophageal junction and esophagus has a very poor prognosis. It is increasing very rapidly in the Western world and seems to be more rapid in the UK than anywhere else. 80% of patients are treated with only palliative intent because of advanced stage at presentation, and often patients who get this type of cancer tend to be unfit. 65% will survive less than a year. There are, as yet, no agreed proven early diagnostic symptom signs. The cytosponge looks promising, although we will have to wait the results of that over the next couple of years. Barrett's esophagus, if we can identify cancers on Barrett's surveillance, small T1 cancer has an 80% 5-year survival. So it is definitely worth diagnosing early if we can.
That concludes this webcast on upper GI cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites. Mm-hmm.